For those of you who don't know me, my name is Scott Shone. I'm the program manager for the Newborn Screening Laboratory in New Jersey. And I have been asked to update the group on the progress of implementation of ALD in our state. I'm actually going to warn everybody to just, this has sort of been our motto a little bit the last, I guess, 2.5 years, because we have been bombarded with some legislation that has really dictated our path, at least in New Jersey, with the exception of SCID, which we got up and running the middle of this year, which was not done by legislative mandate, but by directive of our state's advisory panel. Everything I'm about to show you is legislation that we've been dealing with. And I'm going to start out with what's called Emma's Law, and I know this is supposed to be about ALD, but our progress on ALD is being guided by our progress on implementing screening for lysosomal storage disorders in the state. So I feel I have to guide our talk, at least start with that. And Emma's Law in New Jersey mandates that we screen for Krabbe, Pompe, Gaucher, Fabry, and Niemann-Pick. And the law was written that we have to screen for all 5 or none. And so that's been part of the delay in terms of implementation. This law was signed by Governor Christie in January of 2012 and had the following 4 requirements, including registration of necessary agents, quality control material, quality assurance methodology, and buying the actual equipment. 18 months later, Governor Christie signed our ALD law, which required that we implement ALD screening within 6 months of these 5 requirements, and they're substantially different from the Emma's Law requirements. And the main differences between the LSD law and the Emma's Law and the ALD law are that the quality assurance, it specifically states the quality assurance material for ALD have to come from CDC, and that ALD has to be on the RUSP. And that the department's advisory panel also reviews the assay. So there are 3 major changes. The equipment was also included, and as I'll show, because of our planning for implementation of Emma's Law, when this law came along, we immediately went into, all right, how are we going to combine everything together to minimize the impact on the program and maximize efficiency for implementing all these disorders. And so, cut to a few months ago, Governor Christie signed a 3rd law called the Let Them Be Little Act, which mandates screening for mucopolysaccharidosis 1 and 2. Implementation is not linked, however, in this law. So unlike Emma's Law, which was all 5 or none, we can add MPS 1 or MPS 2 separately under the law as the requirements are met. And they have the same exact requirements as the ALD law, including inclusion on the RUSP, review of the test, and provision of quality assurance materials from CDC. Now, I'll say that the laws don't state that we cannot begin screening before the conditions are met. We just have to begin screening within 6 months after all the conditions are met, right? And I say that because we have a state advisory panel, and they have been discussing these disorders, both before the laws were passed as well as after the laws have been passed. And last month we had a presentation from the Kane family in New Jersey who was successful in getting the law passed for ALD to discuss recommending addition prior to inclusion on the RUSP, which is the major barrier right now for ALD screening. But I'll go back to LSDs, and at the APHL meeting last, what is it, like 3 weeks ago? And it's been a whirlwind. Somebody said, getting this running on mass spec is easy, just do it. And that was met with similar responses, and then also some anger. And I would challenge you to, I challenged the individual, and we've had an interesting dialogue back and forth on it's just not just do it. And this is just a piece of our project plan for getting Emma's Law up and running in New Jersey. And what you see here is a snapshot of just getting the equipment, moving our existing mass spec infrastructure for amino acids and acylcarnitines to a separate part of the building so we could gut our mass spec lab to actually update it to accommodate LSDs and ALD screening. We moved in 2011 to a brand new building, so people are saying you have to renovate a brand new building. Well, the 2011 building was designed in 2006. In 2006, none of this was on the radar. The room was designed for 6 mass specs, but not the separate chemistries involved. And that's fine, and we're undertaking that, but that's a laborious process. And New Jersey is well known for making things not as streamlined as I'd like them to be, and so it takes time to, I forgot I'm being recorded, so I had to be politically correct in mid-sentence. You know, it takes a month for code review, it takes 3 months for a bid process, then there's a 30-day challenge period, then awards are made, and so we're not guiding the timeline here, which is frustrating beyond belief for somebody who likes to lead processes like me. The good news is that because of all the built-in time that we have to make, we're making big strides, and I'll talk about that in a second, in terms of getting the assay working with NIMEC and Joe and then our external partners at CDC and even PerkinElmer as a vendor, so that when the room is ready for us to inhabit, we hit the ground running full steam. And so this is a complex project plan, but the good news is at the end of this, we'll be well situated from a laboratory perspective to have a screening method in place for the 5 LSDs, and when the time is right for ALD, and when the time is right for MPS 1 and MPS 2. And I'll say that from a laboratory perspective. And I'll go into depth as why it's not easy. I'm not going to go into depth as to why it's not easy, but, and I don't put these up, I'll steal a line from Sue Barry, I don't put these up so that you can read them, but to make you impressed as to how much work we're doing. The left side is our current infrastructure, and all of this stuff, dotted lines, and is being X'd out and deleted, and we're building all this new for electrical, HVAC, 3 new fume hoods, all new gases pumped in. It's a major undertaking. We've become, my degree was in molecular microbiology. I then had to learn biochemistry for newborn screening, and now I'm a contractor. Because you have to really guide these things, otherwise you don't get what you want, or more importantly, what you need to do this right. The good news is we're making progress. So from an infrastructure standpoint, that ball is rolling at a decent pace, and we're on track with our project plan to meet our goals. What's the goal? We should be inhabiting our new lab in May to June of next year and begin validating, pilot studying through the end of next year, with hopefully getting everything running at that point. But staffing is a big concern as well. In New Jersey, we've lost 6 technical staff in the last 18 months, and we haven't been able to replace any of them. Meanwhile, we got SCID up and running, and we're challenged with the disorders I just mentioned. So the good news is we are in the process of hiring 3 lab techs. They're basic laboratory technicians. Just take a kit and perform an assay, which is not available for all of this. So we're looking at hiring an actual research scientist to do molecular biology. I'll talk about that in the next slide. An actual supervisor to run the LSD unit. It'll be separate from our amino acids and acylcarnitines unit. And then a principal medical technologist to work with that individual to work and oversee the staff. Now, I mentioned a molecular biologist. When we had the Pompeii Symposium last year, which was a phenomenal meeting, and I'll say that this has been in the same vein, and just completely overwhelming, and thank you to Kathy and Bonnie and Michelle for organizing everything. It really opened our eyes to what do we have to do to get Pompeii screening or LSD screening going in New Jersey, and it shifted our focus from just doing mass spec and throwing our docs, everything, to how can we help hone the message, and we decided we really need to expand our molecular offerings in New Jersey, similar to what they're doing in New York. We have a great partnership with New York in our state now. And so we decided to put a lot of effort into adding mutation analysis, sequence analysis, and that sort into our program to help improve our screening methods. And so we're looking to hire a full-time molecular biologist, but as I said, we've had no luck getting that approved yet in the department. And so APHL, the Association of Public Health Labs, in conjunction with the CDC, announced the opportunity to host a molecular biology fellow for 2 years in your laboratory, and several states applied, and we were lucky enough to be awarded the fellow. We're interviewing right now, and we hope to start this person at the beginning of the year, and this person's main goal will be to drive development of molecular assays in New Jersey, whether they're adopting things that are done in other states or novel assays circling around LSDs and ALD, and anything that comes down the road, whether it's on the radar SMA or DMD or whatever else might pop up, as well as improving existing technology. So we have SCID and CF running. We're looking to expand our CF mutation analysis beyond the simple delta 508 we do, adding galactosemia mutation analysis. But on the right here is really where the main focus is. We do have 2 ion torrents in our facility, not in our laboratory, but in our facility. So we have the opportunity to do all the genetic sequencing that we've talked about over the last 24 hours. So that's the laboratory. And I'll speak for my counterpart in follow-up who's sitting here, who is the first line, the new director of the follow-up program, Dr. Claudia Paulette, who's sitting in the audience. That was a major need for our follow-up program because the director of special child health was also directly overseeing follow-up, and that was taxing. They were able to hire a new public health representative who is the boots on the ground follow-up person in our program. But they're looking now to hire, and in the process of hiring, a new public health rep, a supervising public health rep to oversee all the individuals who are going to take on the burden of following up all these additional cases. We're in the process of convening our LSD consultant group task force to help with bringing in the algorithms from other states and getting them up and running, and developing all the educational material for our state program. We are not looking to recreate the wheel here. One of the benefits of being a little delayed is we're going to learn the lessons from our counterparts in New York and Missouri and Illinois and what they're doing, and hope take the best of everybody's and go from there. Okay, so now we can panic and freak out. Because what I just talked about is the newborn screening program, and what we've been talking about at length, both here in the last 24 hours, but in the newborn screening community in general, is this is a system, and I cannot say conclusively that this system is ready for all of this. Whether it's nationally or New Jersey, this is my greatest concern, okay? Because what I talked about here is testing and follow-up. I don't see from my ankle, but follow-up's in there somewhere. Case management. We don't call follow-up case management, right? But I don't know if the baby's ready. I don't know if the parents are ready, the hospitals, the stakeholders, Medicaid. And that's the biggest challenge we face in New Jersey as well as every other state that's undergoing this. And that's my biggest concern right now. And I think that's where we'll have to focus a lot of our energy over the next year as we get these things up and running to make sure this whole picture is ready. I'll give credit to Susan Tanksley from Texas for developing this. I love this slide. I use it in almost every talk now because it's really shaped how I think about newborn screening. We can't just think about this as the laboratory or the follow-up or the parents or the hospitals or the consultants. It's everybody. We're partners with the same goal, is to make sure this baby's healthy. So this is a slide of the current status of the RUSP. So it's no secret, and it was mentioned yesterday by our advocate fellow colleagues that ALD is not currently on the RUSP. So by the take of the law, the only requirements under the law that are currently met is there's a test or series of tests that's reliable and in use. New York has proven that. And we are in the process of acquiring the equipment. We haven't quite gotten it yet. Money's allocated, the orders are in process, but we're not taking delivery to the rooms done because it doesn't make sense to have $1 million in equipment sitting in a warehouse. So as far as ALD is concerned, which was the whole point of this presentation, I'm not saying that we're going to wait for these. We very well might be in a position where our advisory panel decides to recommend adding it sooner than these are met. But that's where we sit right now. So I can take any questions.